Hi, I'm Dr. Jennifer V. Brown, your stroke specialist. I'm aging gracefully with stroke due to sickle cell disease. And today we're going to discuss how to improve balance for walking after stroke. Target the trunk. So, the trunk is really critical as it is the stabilizing point for the arms and the legs to move. But you have to discern what's the impairment of the trunk so that you provide the right interventions. So, is it a discoordination problem versus a weakness problem? Discoordination is a problem of the vermis when you have a lesion to the cerebellum, but a weakness of the trunk may be due to the damage in the pons in the medulla because of the impairment is at the reticulospinal tract. You have two of them. One's medial and lateral. They either cause the trunk to do overall flexion or extension. Now, there are other muscles of the trunk that attach to the scapula that have different nerve innervations, and they may be damaged at the cerebrum part. But I see a lot of trunk weakness with overall impairments in flexion and extension due to a lesion down into the pons in the medulla. So when you do the assessment, use the trunk impairment scale, but there are two types. The Fujiwara is one that really focuses on the discoordination, but the Verheyden, when you have hemiplegia and one side is weak, that is the most optimum scale. And it looks at movement of the legs versus the arm and coordination of the trunk to assess weakness in the trunk. Remember, your treatment should be task specific. You need repetition, progressive difficulty, and don't forget cognitive engagement. A few other things: error, let the person make a mistake, problem solve, and try to learn. So I do a lot of interventions for the arms. Here we call it the upper extremities to engage the trunk. Now I am not doing a lot of overhead lifting with a straight dowel rod or cane. When I didn't have a dowel rod, I use a cane. I use a square or triangular piece of PVC piping because I don't want the arm in internal rotation as it goes up. I'd rather it be in external rotation with the thumbs up. But when you use TheraBand, and you have to push against that and hold it steady and then bring the dowel rod or cane back towards you, you're really engaging trunk muscles. I do it in sitting and I do it in standing, and then I do it in transitional movement. But you can tell the person here is weak in the trunk because look how wide the base of support is. And he's not really steady. And then when he comes to sit, he's afraid to flex forward. That may be a weakness of his gluteus maximus because your gluteus maximus also controls the pelvis and the trunk. But let's look at some other things that I do to engage the trunk. I do lots of kneeling. Why kneeling in a chair? People are arthritic and they have an extensor synergy pattern, and I'm trying to lengthen the rectus femoris as well as the quadriceps femoris. So you can see she was using a cane kneeling in the orange picture without any TheraBand, but now I have her kneeling using a square PVC piping. She has to lift it above her head. Notice in the bottom picture, I have that TheraBand wrapped around her arm. So now it may engage more of her tricep, and she's straightening the arm so it's a longer lever arm, which will engage the trunk more. And you see pictures of me here standing, and I'm using a U-shaped PVC pipe, PCV piping, in which I connected the TheraBand and I'm pulling in forward. So I'm lengthening the muscles of my trunk. And then I'm going backwards with the TheraBand resisted right below my belly button, and I am pushing backwards. I've done these techniques with rotation components, with walking. I've done them with the PVC piping shaped like in a V. So how you, in what type of shape the PVC piping makes a difference on how the muscles are activated. So I do a lot of movement to enhance the work of the external obliques by the use of TheraBand. And they saw in the research that when you use the non-paretic upper extremity, it impacts the abdominal muscles, particularly the external obliques. So you have to move the shoulder into extension, meaning getting the shoulder joint behind your body, but the movement is horizontal abduction, but you also get that elbow. So from here to here is horizontal abduction, but when you get it behind you and you get into extension, you really activate the external obliques. So make sure you can do this activity in sit or stand. I usually do it in sitting if there's not good trunk stability, and then I move into standing. Then I change the position of the feet, and then I make them stand on a dynamic or compliant surface like foam mats or rugs or pillows with different foot positions, and move that non-paretic arm to activate the trunk. These are some clinical questions to ask. Is there a lesion of the vermis, a part in the cerebellum, the middle part, impacting trunk coordination? Or is there a lesion of the medial or reticulospinal tract causing strength deficits and overall flexion and extension of the trunk? Remember, you can have lesions on the cerebrum that impact muscles of the trunk that connect to the lower extremity or the shoulder girdle. Is there a sensory deficit or perceptual deficit causing a whole midline shift? And this is when you have a perception that your body is on one side and you shift your head and then the trunk follows. And then again, how do you best optimize use of the upper extremities to engage muscles of the trunk? Don't forget, I am your trusted source for all things ankle foot orthoses and stroke neurorehabilitation. Scan the QR code and go to my website. Send me an email if you're interested in this book. It's on sale. I'll tell you the discounted price. You can get everything you need to know about the physical therapy examination so you can make recommendations for the best fitting and functioning ankle foot orthosis. And don't forget about the references. We need to use evidence based practice in order to optimize the health outcomes for our clients. Thank you so much for listening to this video. Bye.